Hello friends, welcome to the session on Pediatric Viva Voce, and on today's session we'll be talking about drugs. What I've tried to do is to cover all the common drugs possible, because in your Viva exams different institutions will have their own preference of drugs, so I have tried to include all the common drugs possible. Okay, fine. Now coming to the first group of drugs, we'll be discussing about antipyretics, and the most common antipyretic used is, as we all know, is paracetamol. So if you are asked about any drug, please go in this sequence. If you guys tell in this sequence, I'm pretty sure the examiner will be impressed. Okay, which it belongs to which class of drugs, then you talk about the mechanism of action, then you talk as to where it is used and what it is used for. Then if you can remember, you guys can tell the dosage of these simple common drugs. Go ahead and tell the dosage. Okay, then few important side effects you guys tell, and then go about telling, if possible, if you guys can remember, how it is available in the market, in what concentration it is available. Now we'll discuss about paracetamol. Paracetamol, also called as acetaminophen. Okay, what is the mechanism of action? Simple. In simple words, you can just explain. It is a COX-3 inhibitor, as we all know. It is used for control of fever as well as mild to moderate pain. It can be used for, and in neonates it is used to close patent ductus arteriosus when it is causing hemodynamic instability in neonates. Okay, mainly in the preterms. What is the dosage? 15 mg per kg per dose when it is given orally. If it is given rectal, again 15 mg per kg per dose, and if given IV, then it is 10 mg per kg per dose. Maximum of 90 mg per kg per day or 4 grams per day oral, and 60 mg per kg per day IV. This is the maximum dose. Toxic dose is important because we do get many cases of paracetamol poisoning. Most of the time it will be accidental in smaller kids, and in adolescents it will be poisoning for the sake of suicidal tendency. Toxic dose is 200 mg per kg or 10 grams, and for treatment acetylcysteine is used. How is it available? It is available in both 125 mg per 5 ml or 250 mg per 5 ml or a 500 mg tablet. And rectal suppository, both 125 mg and 250 mg is available. But coming to the adverse effects, it is a very safe and well tolerated drug. In higher toxic doses, it can cause hepatic damage. Next one is mefenamic acid. Mechanism of action: reversible COX inhibitor with PG receptor antagonist as well. So prostaglandin receptor antagonist as well, along with COX inhibition. It can be used as antipyretic. It is a good analgesic, and it has good effect for good efficacy in dysmenorrhea. What is the dosage? For antipyretic dose, it is 5 to 8 mg per kg per dose 8 hourly. As an analgesic, it is 25 mg per day 8 hourly. How is it available? 100 mg per 500 ml syrup or 250 or 500 mg tablets. This is also a safe drug, and few adverse effects include diarrhea and skin rashes. Next common antipyretic is Ibuprofen. Mechanism action is same, COX inhibitor, and it is one of the safest NSAID that can be used. So for pain relief, we can use Ibuprofen in pediatric population. Dosage is 5 to 10 mg per kg per dose, given 6 to 8 hourly, maximum of 40 mg per kg per 24 hour. And how it is available? Same, 125 mg per 5 ml or 100 mg per 5 ml. Adverse effects are very much less as compared to aspirin, and hence it is one of the safest NSAID. Next, coming to antihelmetics, and the most common used is albendazole. Okay, this is an important drug that can be asked because it is there in a national program as well as deworming day, and it is a broad spectrum antihelmintic. Mechanism of action: it alters the cytoskeletal structure of the parasite, and due to its broad spectrum activity, it is indicated for deworming, and this is the drug that is used for on National Deworming Day. Deworming is presently done twice a year by Indian government. National Deworming Day, when is it done? It is on February 10th. Okay, if there is high prevalence, then even second round of deworming is carried on, and this is done on 10th of August. Age group included is from 1 to 19 years, 200 mg for children up to 2 years and 400 mg for the rest. How is it available? It is available as a suspension, that is 400 mg in 10 ml suspension. What drug they will ask you is to carry will have 400 mg in 10 ml. Next we will discuss about the, it's not possible to discuss all the antibiotics, we will discuss about few of the common antibiotics that is used. First one will be Amic Acid. Which class of drugs it belongs to? It's an aminoglycoside. It inhibits peptide synthesis, fine. Then what are the properties it exhibits is concentration dependent killing and post antibiotic effect. Okay, hence it can be given only once daily because of its post antibiotic effect, and once daily when we give it, we'll have to give it at a good high dose because it has concentration dependent killing. Main action is against gram negative and aerobic bacilli. Dosage is mainly 15 mg per kg per day given IV, and side effects include nephrotoxicity and ototoxicity. Coming to ampicillin, it is an extended spectrum penicillin. It belongs to that. What is the mechanism of action? It acts by inhibiting the cell wall synthesis. Correct. It is effective against gram positive cocci, bacilli, along with few gram negative organisms. It is usually given IV. Okay, the oral formulation is available. Dosage is 100 to 200 mg per kg per day 6th hourly, and 200 to 400 mg per kg per day for meningitis. Side effects includes hypersensitivity reactions. Fine. So ampicillin, it is one of the most basic drug used, so please be aware of it. Next is amoxicillin. It is similar to ampicillin mechanism of action, but amoxicillin is given orally. Okay, this one cannot be used for meningitis. Dosage is 25 to 100 mg per kg per day 8 to 12th hourly, either BD or TID. If given IV, though usually it is not given, it is 50 to 100 mg per kg per day IV. How is it available? As 125 mg per 5 ml or as 250 and 500 mg tablets. When this amoxicillin is combined with clavulinate or clavulinic acid, what happens? As we all know, the mechanism of action of clavulinate is a beta lactamase inhibitors. Hence, this combination is effective. The ampicillin alone might be deactivated by beta lactamase producing organisms, but if we have clavulinic acid which acts as a beta lactamase inhibitor, it is much more effective. Correct. So it is effective against beta lactamase producing organisms as well. How is this formulation available? It is available as amoxicillin with clavulinic acid. Okay, so 156 mg per 5 ml or 228 mg per 5 ml or 457 mg per 5 ml or as tablets, 625 mg tablet or 375 mg tablets. Next is ceftriaxone, third generation cephalosporin. Okay, it's a third generation cephalosporin, and it is resistant to beta lactamase producing organisms. It is highly effective against gram negative cocci and bacilli and few anaerobes as well. What is the dosage of Cetri? It is 50 to 75 mg per kg per day, which is usually given as a BD dose. If we are using it for meningitis, then we give it at a higher dose, 100 mg per kg per day. Hypersensitivity reactions and pseudomembranous colitis are few of the side effects, even diarrhea as well, because it alters the gut bacteria. Okay, next comes Cefixim. This is also a third generation cephalosporin, and this can be given orally. Since Cetri only IV formulation is given and no oral formulation is available, we in general, if oral formulation is required, we use Cefixim. This is again one more important question that they'll ask in Viva. Okay, Cetri is not available as an IV, as a oral medication. It is usually given IV. Now Cefixim is given orally. Dosage is 8 mg. Rest all is mechanism of action, everything is similar to Cetri. Okay, because this is also a third generation cephalosporin. Dosage is 8 mg per kg per day once, or usually given twice daily. If we are using it for enteric fever, then a higher dose has to be given, that is 20 mg per kg per day. How is it available? 200 or 400 mg tablets or 50 and 100 mg per 5 ml syrup as well is available. Next is vancomycin. Vancomycin belongs to glycopeptide group of antibiotics. How do they act? They act by inhibition of cell wall synthesis. When is it used? It is effective against aerobic as well as anaerobic gram-positive species, and it is usually limited to treatment of serious infections caused by MRSA, methicillin resistant Staph aureus species, okay, or pseudomembranous colitis that is not controlled by metronism. Vancomycin is always given IV. Though linezolid both oral as well as IV is available, vancomycin it is only IV. Fine. So it is given as 40 mg per kg per day 6th-hourly and 60 mg per kg per day for CNS infections. Side effects, this is a famous MCQ question as well. It causes red man syndrome due to histamine release. Next one is azithromycin. It belongs to macrolide group of antibiotics. How do they act? They act by inhibition of protein synthesis. It is used to treat mainly atypical organisms like mycoplasma, chlamydia, H. influenza, pertussis, etc. Okay, it is given orally. How do we give it? On first day we give it as 10 mg per kg per day on empty stomach. Okay, that is followed by 5 mg per kg per day during the next 4 days. Maximum of 500 mg. Fine. Side effects include allergic reaction, QT prolongation, cholestatic hepatitis, etc. How is it available? It is usually available as 500 mg tablet or 250 mg tablet. Next group of drugs under antibiotics includes ATT, Anti-Tuberculosis Treatment, correct? Now the first line drugs includes Isoniazid, Rifampicin, Pyroxenamine and Ethambutol, and you are expected to know about all these 4 drugs. Fine. You will be given the sheet which is used for ATT, and you will be asked to explain regarding it. So all are, next important question that will be asked is, all are bactericidal except ethambutol which is bacteriostatic. So usually they'll ask which is bacteriostatic, and you guys will have to give an answer telling ethambutol. What is the present drug regimen that is being followed? As per NTEP guidelines, recent NTEP guidelines, there is only one class of patient, the class A and class B has been removed, and the regimen that is followed is daily regimen, not alternate day. It is daily regimen of 2 HRZE plus 4 HRE. So intensive phase contains of 2 months of HRZE followed by 4 months of HRE. Fine. Except for neural and spinal TB, wherein the continuous phase is extended for 10 months. Fine. Next they'll ask what is new in the treatment. Okay, what is new is addition of ethambutol in continuous phase. Presently it is the daily treatment that is being followed. Fine. And there is no extension of intensive phase in case of poor response. If in the case there is poor response, we go ahead and investigate for drug resistant TB. Fine. Yeah, category 2 has been removed. We have already discussed about it. Fine. Fine. That much is enough for us to know. Fine. Next is drug dosage and fixed drug combination. This is the recommended dosage, but it's okay. I don't think so. They're gonna ask you guys this. Okay. And this is they'll ask what is the pediatric formulation, what is the pediatric formulation, and what is the content of each pediatric formulation. Isoniazid is 50 mg, rifampicin is 75 mg, pyroxenamide is 150 mg, and ethambutol is 275 mg. And what is different in between pediatric and adult formulation is, in pediatric formulation you will get ethambutol as a separate tablet. Okay, so one tablet contains HRZ and one more separate tablet of ethambutol is given as compared to adults. So this is one of the difference, and each formulation will have isoniazid 50, rifampicin 75, pyroxenamide 150 and ethambutol 275 mg. Fine. And pyridoxine is given along with all. Whenever we give ATT, we'll have to prescribe pyridoxine as well, and dosage is 10 mg daily. Next MCQ question that will be asked, next Viva question that will be asked is, what is the role of steroids? Fine. Where all we will use steroids in case of TB? We use it in case of central nervous system, that is TB meningitis. Then we use it in case of TB spine, which causes cord compression, miliary TB with alveolo-capillary block, or TB pericarditis. If there is adrenal involvement, if there is endobronchial TB which causes airway obstruction, vasculitis or aortoarteritis, TB uveitis, and during immune reconstitution syndrome management. Fine. Next, few common side effects. Isoniazid, we know it causes hepatotoxicity and peripheral neuropathy, and that's why we give prophylactic pyroxene. Rifampicin, orange discoloration of secretions, but this is a normal phenomena, so we'll have to counsel patients regarding this. And hepatotoxicity. Fine. Next, there is pyroxenamine that causes again hepatotoxicity, joint pain, hypersensitivity. Ethambutol is known for its ocular toxicity, dose dependent ocular toxicity. Fine. So these are the first line drugs, and these are the few side effects that we have to remember. Next, coming to cotrimoxazole. This is one more important syrup that can be kept in your Viva Voce. It belongs to sulfonamides group of drugs. How do they act? They act by inhibiting folic acid synthesis. Next, it is active against gram-negative organisms. It is used as an anti-malarial, and it is used against toxoplasmosis as well. Clinical uses, it is used against UTI. It is used for prevention of UTI. It is used for respiratory tract infection as well as its prevention, typhoid, STD, dysentery, etc. Dose is 5 to 8 mg. The examiners are very fond of cotrimazole, so please remember the dosage of cotrimazole. It is 5 to 8 mg per kg of cotrimazole, 25 to 50 of trimethoprim, and 25 to 50 mg per kg of sulfamethoxazole. If it comes to typhoid, we use it as 10 mg per kg, and for PCP pneumonia, it is 20 mg per kg. If we are using it for prophylaxis, if for example we have a HIV patient and we are using under 5 HIV patient, we need to give prophylaxis as a prophylactic dose. In that case, the recommended dose is 5 mg per kg for PCP pneumonia, and if it is against UTI, then it is 1 to 3 mg per kg. And now how it is available? It is available as 40 mg of trimethoprim, 200 mg of sulfamethoxazole, okay, per 5 ml syrup, and as tablet it is available is 80 bar 400 mg. Few of the side effects, why we don't use it in neonates, because of the possibility of it causing kernicterus, hypersensitivity, and crystalluria. So we have covered most of the basic antibiotics. Now next we'll move on to anticonvulsants. Few common anticonvulsants that are used: lorazepam and midazolam. They belong to benzodiazepines. How do they affect? How do they act? By enhancing the frequency of the inhibitory channel. So GABA mediated chloride channel opening. What is its clinical use? It is mainly used as first line agent in status epilepticus. Dosage for is 0.2 mg per kg IM, or intranasal spray, or is used as 0.3 mg per kg, and lorazepam is 0.1 mg per kg per dose. Few of the side effects are sedative effects, development of tolerance to their anticonvulsant effects. Next is levetiracetam. This is one of the newer anti-epileptic drugs. It acts by inhibiting synaptic vesicles containing glutamine to fuse. So it inhibits the synaptic vessel fusion to the membrane, correct? So in the end, glutamine is not released, which is one of the excitatory neurotransmitter. So it is a broad spectrum anti-seizure medication. It is again, the dose is 50 mg per kg per day. Formulation available is 100 mg per ml syrup. Levipil is available as 100 mg per ml syrup, or 250 and 500 mg tablets. It is usually a safe drug, so few of the side effects include dizziness, weakness, suicidal tendencies. Next is Phenytoin. They act by decreasing the glutamate release. Okay, decreasing glutamate release, mainly used to treat GTCS type of convulsions. Okay, and it is one of the first line drugs in status epilepticus. Phenytoin should never be used in case of absent seizures or myoclonic seizures because it will exacerbate them. Fine. It is also used to treat other conditions like trigeminal neuralgia, and it is one of the class of drugs that is for ventricular arrhythmia. Dosage of phenytoin is 5 to 8 mg per kg per day. How is it available? It is available as 30 mg per 5 ml syrup. Side effects will be gingival hyperplasia, megaloblastic anemia, vitamin K deficiency, hirsutism, congenital malformations. We are aware of all these things. Next, coming to valproate. So the mechanism of action of valproate is by decreasing the release of glutamate and increasing GABA activity. So since it acts on both, it has a very broad spectrum activity. So it can be used for GTCS, it can be used for absent seizures, it can be used for myoclonic jerks, it can be used for infantile spasms, and it is one of the first line drugs in case of status epilepticus. Dosage of valproate and phenytoin remains the same. Valproate and Levipil dosage will remain the same. Phenytoin and Phenobarbiton dosage will remain the same. So an easier way to remember is that. So again, valproate will be same as Levipil, 20 mg per kg per day. How is it available? It is available as 200 mg per 5 ml syrup. Side effects can be hepatotoxicity, pancreatitis, thrombocytopenia, GIT problems, alopecia, and tremors. Coming to phenobarbital, it belongs to barbiturate class of drugs. Mechanism: it enhances GABA mediated inhibitory effects and also inhibits glutamate mediated excitatory effects. It is used mainly for GTCS type of convulsions and first line drug in case of neonatal seizures. Dosage is 3 to 5 mg per kg per day, 12th hourly. Fine. Next, coming, how is it available? It is usually available as 20 mg per 5 ml syrup. Good sedative effect it has. It has and it also has various. It causes drug interaction with other drugs, irritability, hyperexcitability, a few of the other side effects. Next question they can ask is name few newer anti-epileptic drugs. There can be vigabatrin, lamotrigine, levetiracetam, topiramate, zonisamide, etc. Then they might ask about the status epilepticus algorithm. So you can go through this algorithm. Fine. So this is the status epilepticus algorithm. This is the most recent algorithm. You guys can later on go through this algorithm once, because they will this is one of the most common presentation. So they will invariably keep few anti-epileptic drugs, and once they ask about anti-epileptic drugs, the examiners do have a tendency to ask about status epilepticus management as well. So please go through this algorithm. Fine. Next is antiemetics, and the most commonly used antiemetic is ondansetron. It's a selective 5-HT3 receptor antagonist. How do they act? They act by blocking 5-HT3 receptors peripherally, fine, and centrally at NTS and chemoreceptor trigger zone. Dosage of antiemetic ondansetron is, if given IV, it is 0.15 mg per kg per dose, maximum of 8 mg per dose, and it can be given up to 4th hourly. Okay. Oral, if less than 4 years, it is 2 mg, which can be given up to 4th hourly. If it is 4 to 11 years, then it is 4 mg 4th hourly. If it is more than 12 years, then it is 8 mg, which can be given up to 4th hourly. How is it usually available? It is usually available as 2 mg per 5 ml syrup, and it is as well available as 4 and 8 mg tablets. Side effects, it usually has a very good very good safety profile. So it causes some minimal side effects like headache, constipation, rashes, etc. Next, coming to the antihistamines that are used. So cetirizine, one of the most common antihistamine used. So again, this will invariably be kept in your exams. Very important drug. It is one of the second generation antihistamine, so it has lesser sedative effect. Mechanism of action, H1 receptor blocker, usually used for common cold. Dosage, if it is 6 months to 2 years, it is 2.5 mg OD. 2 to 6 years, it is 2.5 mg or 5 mg or 2.5 mg BD or 5 mg OD. If it is more than 6 years, then it is 5 to 10 mg OD or BD. Okay, it is usually avoided in children less than 6 months. Formulation is 5 mg per 5 ml syrup. That is how it is available. Again, side effects of almost all the antihistamines will be sedation, though it has lesser sedative effect as compared to first generation, and antimuscarinic effect as well. Chlorphenylamine malate, CPM, this is one more important drug that can be kept. It is one of the first generation antihistamine, so it has more sedative effect. Mechanism remains the same, usually used in treatment of common cold, and this can be used in smaller children as well. Fine. So dosage is 0.35 mg per kg per day, Q630. How is it available? As Synerist AF drops, 2.5 mg per ml or 5 mg per 5 ml. Next one is Phenylamine Malate. This is again nothing but the popular drug, that is Evil. Okay, this is one of the popular drug, correct, which we use for any of the allergic reactions, or once we give blood products, if they develop any transfusion reaction, this is the one of the first line drugs that is used. So that is Phenylamine Malate. This also is one of the first generation antihistamine. Dosage is 0.5 mg per kg per day, which can be used TID. What is the formulation that is available? 22.75 mg as 2 mg ampule. Next, coming to the emergency drugs. So 3 common emergency drugs is inotropes that can be used is epinephrine or adrenaline, norepinephrine and dopamine. So epinephrine, it is one of the catecholamine, sympathomimetic and vasopressor. Fine. What is the mechanism of action? It stimulates both alpha as well as beta adrenergic receptors. It is indicated in case of any shock, we give this. It is one of the first inotrope that is used. Fine. And in the PALS, manual as well, this is one of the, in case of cardiac arrest, this is one of the first line drug that is used. Okay. Now dosage, it can be given as IV infusion, which we, in case of shock, we start it at 0.1 micrograms per kg per minute, and we can go up to 1 microgram per kg per minute. Few of the adverse effects include CNS, CVS, GIT and others. Okay, these are few of the side effects. Okay, next is dopamine. Next inotrope that we use is dopamine. What is the classification? Direct and indirect acting sympathomimetic. It is a cardiac stimulant. It acts as a vasopressor. Okay, and all these actions are dose dependent, depending on the dosage which we use. Okay, so when we use it at a dose of 5 micrograms per kg per minute, it usually causes increase in renal and mesenteric flow, thereby improving perfusion to few major organisms. At a rate of 5 to 15 microgram per kg per minute, dopamine usually acts as a cardiac contractility drug and increases cardiac output. Fine. And in this dose, it has very little effect on vascular resistance. So it is unlikely to cause tachycardia at this dose. So more than 15 micrograms per kg per minute, at 20 micrograms per kg per minute, it also acts as vasopressor, causing peripheral vasoconstriction. Fine. Indication, hemodynamically significant hypotension. Again, in case of shock, this is one of the first line drug that is used. Okay. Next, coming to norepinephrine. This is also again a catecholamine, vasopressor and sympathomimetic. Norepinephrine usually stimulates alpha adrenergic receptors, producing vasoconstriction and increasing peripheral vascular resistance. Then it stimulates only, not all, but only beta 1 adrenergic receptors, and thereby it increases cardiac contractility and cardiac output. This is also the drug that is used in shock accompanied by hypotension. Usually this is used in case of warm shock we use norepinephrine, cold shock we use epinephrine. Fine. Next, what is the drug therapy in case of cardiac arrest? What is the dosage of epinephrine used? Again, this is one very important question that you will be asked. Okay, the dosage used is either 0.1 ml per kg of 1:10,000 concentration. That is, the ampule that is available is 1:1000. So we take 1 ml, dilute it in 10 ml syringe. After that we can use it as 0.1 ml per kg. Okay, which we repeat every 3 to 5 minutes. If intraosseous or IV access is not available, then we can go ahead and give through endotracheal tube as well, and in that case dosage is 0.1 mg per kg. Okay, and in case of 0.1 ml per kg of undiluted adrenaline. Okay, fine. Next group of drugs that you can be asked, and this is one of the thing which you will invariably be asked, so very important, is bronchodilators, because this is one of the most common case which you can get in your OPD. So this, or in the emergency department, so this will again be asked. Now this is from the recent guidelines, so you guys need to be aware of what is the step 1, step 2, step 3, step 4 and step 5 management. Okay, now the one that is above is the preferred one. Okay, and the change that has been made is over here. See, the reliever therapy and controller therapy as well. The first line, or the one that is being presently used, previously the reliever used to be short acting beta 2 agonist and controller used to be inhaler corticosteroid, but presently both reliever as well as controller is inhaled corticosteroid with formoterol. Okay, that is called as the MALT therapy, nothing but the full form is maintenance and reliever therapy. So this has been recently introduced and this will again be asked in your Viva. Be aware of this maintenance and reliever therapy, that is low dose inhaled corticosteroid and formoterol. Fine, and these are the step 1, step 2, step 3, step 4 and step 5. Be aware of what are the symptoms and what is the treatment of choice. Fine, go through this algorithm. Next is management of status asthmaticus. Again, this is the next algorithm. This depends if it is mild or moderate severity and severe exacerbation. So either it is mild, moderate or severe exacerbation. Be aware of the definition of mild, moderate and severe exacerbation. Okay, and in case of mild or moderate, then how do we treat? We usually treat it, the preferred modality is to treat it with MDI with spacer. Okay, with 4 to 10 puffs of short acting beta 2 agonist repeated every 20 minutes for 1 hour. Then we start the patient on oral prednisolone at 1 to 2 mg per kg. Okay, and we also use controlled oxygen. Fine. After doing this, we assess the response. If patient responds, then we discharge the patient. We discharge the patient on controller therapy. Okay, and the present controller therapy of choice is low dose inhaled corticosteroids with formoterol. Okay, along with prednisolone for 5 to 7 days. In children, it is 3 to 5 days. Okay, this is for mild to moderate exacerbation. Now, what about severe exacerbation? In that case, we can give initially salbutamol up to 3 doses separated by 20 minutes, and whatever nebulization we give in case of severe exacerbation should be given with O2 with 6 liters flow. That is very important. Fine. So salbutamol dose will be 0.15 mg per kg per dose. Maximum is 5 mg. Okay, up to 3 doses can be given. After that, what we can give? We can give Ibuprofen Bromide. Why Ibuprofen Bromide after salbutamol? Because we all know the Ibuprofen Bromide acts better on a airway that is already salbutamalized. Correct? Salbutamalized airway Hypnotropin Bromide acts better. What is the dose? 125 micrograms less than 1 year, 250 micrograms 1 to 12 years, and more than 500 micrograms for more than 12 years. This is also given every 20 minutes up to 3 doses. Then we can give Budecort nebulization. Okay, we can also give hydrocort injection in case of status asthmaticus initially at 10 to 10 mg per kg per dose stat, followed by maintenance dose of 5 mg per kg per dose given 6th hourly. We can also give adrenaline at 0.01 mg per kg per dose, maximum is 0.5 ml. This can be repeated up to 3 dosages after 15 to 20 minutes. If still not relieved, we can go ahead and try magnesium sulfate. Okay, though the role is questionable, still it is being practiced. It is around 50 mg per kg per dose in 30 ml NS over 30 minutes. Fine. If still not working, we can give Aminophen infusion, that is 5 mg per kg loading dose followed by continuous infusion, and the rate of continuous infusion, the dosage differs with the age, but we can remember, what we need to remember is 5 mg per kg per dose of loading dose. Okay, if still not relieved, then we should have to intubate the child and put the child on ketamine infusion. Fine. So that's it, guys. Guess we have covered most of the common drugs, emergency drugs, and important drugs that is required for the Viva. Fine. So hope this class was useful. Thank you, guys.